It is my pleasure to give the first lecture, and this one is going to be on infection and inflammation imaging. My only disclosure is that I'm a consultant for Endocrinology, which has nothing to do with this talk. So in terms of my objectives, I have three objectives. The first is to discuss the new role of PET-CT in evaluation of infection and inflammation for outpatients. We're going to talk about the role of PET-CT in evaluation of inpatients. We do have quite a bit of experience on that for patients with fever without a source. And I do want to talk a little bit about the economics and talk about the relative imaging costs of various radiopharmaceuticals that we can use for infection and inflammation. So first, I was very, very happy in January of 2021 when CMS finally allowed the MACs, Medicare Administration contractors, to cover FDG PET for infection and inflammation. For a long time, there was a national non-coverage determination for FDG PET scans for infection and inflammation imaging. So they stopped this in January of 2021, but it wasn't like a light bulb. Once they stopped it, it didn't automatically mean that you could get outpatient PETs for infection and inflammation. So what we did as a society level, and one of the hats that I do wear is I'm the chair of the ACR for the Commission on Nuclear Medicine and Molecular Imaging. We work together with other organizations, SNMI, ASNIC, ACNM, and met with various local MACs in different areas, some of the big ones, Noridian, Palmetto, and we were discussing with them how important this change is and why they should cover patients for outpatient imaging. And this was a collaborative effort. For example, we started meeting with them around March and April. And we had leaders from on various organizations, as well as the staff, try to coordinate this. And we thought that this was going pretty well. And this was very, very exciting. But we did have some hiccups along the way, because even though initially CMS said that everything for infection and inflammation would be covered as an outpatient, we were very surprised in June of 2021 when the CMS updated the national covered and non-covered ICD-9 indications. Unexpectedly, some of the ones that we thought would be covered were not, including osteomyelitis and fever of unknown origin. So that also kind of put a stop to outpatient infection inflammation imaging. But we were very happy that, with talking with CMS, about 2 months later in August, they revoked the non-coverage codes initially submitted in June. And now there's no restriction on infection or outpatient imaging for FDG PET-CT. However, having said that, we still have pushback from our local MACs sometimes on the indications to do. We've done about 10 outpatient for aortitis and other infection inflammation imaging, but we really should be doing a lot more. And I'm just curious, by a show of hands, how many of you have done outpatient imaging for infection and inflammation at your institution using FDG PET? Has anyone else done? Okay, a few. But I think we still have a lot of progress to go on this. And I think this is one of the situations where initially there's a lot of resistance. But once we have the momentum going, it's really going to really open up this area.
And I have the fortune of introducing this very exciting topic to the audience, theranostics. All of us faculty here are very interested in theranostics, and actually a lot of us came into nuclear medicine with this in mind, that this would be a big part of our career, particularly in the field of nuclear medicine. Some of you may know used to have a lot of internists like myself, and then subsequently did nuclear radiology. So hopefully this will give you a quick overview of the perspectives you'll be hearing after me from Dr. Sekutinsky and Dr. Wang, who will give you more specific updates on the hottest topics. So in way of disclosure, as you've seen before, if you've been listening to my talks, I'm the Senior Medical Director for Envigro, a Konica Minolta company, and have also commercial ties with Amgen, Bayer, Blue Earth Diagnostics, Chimerix, Eisai, Fusion Pharma, GE Healthcare, Novartis, and Neuro today. So the objective today is to provide an overview of the past, present, and future of theranostics with radiopharmaceuticals. So theranostics is an evolving terminology. It's hard to say who actually first came up with the term or a similar term, but a lot of people attribute it to Dr. Funkhauser in 1998, who used the term actually just in a press release for his company at the time to describe a material that could combine diagnosis, treatment, and follow-up of a disease. So as you can see in that name, it doesn't actually necessarily say anything about radiopharmaceuticals, okay? There's a newer, broader definition that I kind of like, and it has more to do with imaging and nuclear medicine. A theranostic system integrates some form of diagnostic testing to determine the presence of a molecular target for which a specific drug is intended. And I'm kind of going to work more with that newer, broader definition. So in this classic keyhole approach to a talk, right, I'm going to first start with more of a broader overview of where does theranostics really fit. And a lot of people put theranostics under this larger umbrella, which everyone's heard of, personalized medicine, okay? So in personalized medicine, there's screening, diagnosis, treatment, and follow-up. And so you have to have integrated diagnostics fall into this personalized medicine, okay? Where to get that diagnostic component, to personalize it, really have to combine data from 3 sources. Genomics, which really helps with your pre-test probability, which we all know is critically important in any kind of screening protocol. Imaging and pathology, okay? That way you can really get at all the biomarker information that you need to really optimize your personalized medicine. And those biomarkers come complementarily from in vitro, like fluid diagnostics for genomics, ex vivo for biopsies like pathology, and in vivo for imaging, right? So we actually kind of are cool because we're in this in vivo bucket, which is an exciting place to be, all right? And from that, again, you can get at-risk patient profile, companion biomarker of targeted drugs for selection response, and we can also do 2 and 3 by being able to early diagnose recurrence too, or localized recurrence after maybe a fluid biomarker is detected that it has recurred. And we also slot very nicely into imaging-based guidance for therapies and treatment, right? So, of course, interventional radiology can play a big role there for image-guided therapies, but also we can collaborate with our radiation oncology colleagues to do radiodiagnosis, and they can do targeted radiotherapy. Nowadays, there's even imaging-controlled drug delivery. We're placing catheters, for example, to deliver radiopharmaceuticals in clinical trials, and cell-based therapy. We can play roles there to determine if we can target cell-based therapy correctly.
So I'm going to be talking to you about response assessment and response criteria using PET imaging. And I'll focus a little bit on some of the commonly used schema for response assessment, both qualitative and quantitative. I'll give a little bit of a caveat at the beginning that in clinical practice, I'm clearly a qualitative person. So I want to convey, what's happening to the patient, and I'll use descriptive terms, and, when necessary, you can call the clinician and talk to them. Frequently they'll call and say, I read your report, but do you think the tumor is getting better? Is it worse? They need to decide what to do with their patients. But there are some schema out there, and particularly for clinical trials, as we validate new drugs and look at new therapies, there are some regimented ways of doing response assessment as well. And so I will address some of those and show you a little bit of data that goes along with that. So what is response assessment? Well, response assessment is the ability to predict long-term treatment outcome. We don't just want to know what's happening to the patient today as we see them in the clinic. We want to use that information to hopefully predict what's going to happen to them down the road. And the shorter that interval of time can be, really the more ideal for the patient. You'd like to be able to decide within a fairly short period of time whether a particular intervention, a course of therapy, is going to be effective down the road. And if it is, you can continue on that therapy. If it's not going to be effective and you can demonstrate that very early on, you could switch them to another therapy before wasting weeks to months on something that ultimately may prove to be ineffective. So the concept that we're trying to aim for is really for PET as a biomarker, using it like we do other sorts of markers. We're used to seeing, histologic markers and serum markers in helping patients decide which therapy to get. Well, imaging can also be a biomarker in a sense, being a way to interrogate the biology of a particular tumor, helping us to decide what the best course of therapy will be. In order for this to be of uniform prognostic value, there are just some things we need to keep in mind. Some of these are achievable with PET imaging. Some of them may be a little bit more difficult. Ideally, we should have a consistent application of our method, consistent criteria for scan interpretation, and uniform performance of the scans, which is always a little bit of a challenge. Those of you who read for various sites have the experience that when it's done on the scanner over here, the images look different than the scanner over here. SUVs are a little bit different, and that's why it gets hard to get to that level of precision where we're overemphasizing the numerical values, and that kind of brings me back again to the qualitative assessment. At the end of the day, we need to be able to look through those images and look through the variability in order to be able to make our judgment. But as much as we can control these factors, the better in terms of uniformity of that response assessment. I'm going to use lymphoma for the majority of the case examples just because I think the field of response assessment is the most mature. For lymphoma, we've been using it for several decades now, FDG PET imaging, to evaluate patients with lymphoma and to look at the response assessment. And lymphoma is a nice one because many lymphomas do respond quite well, and when they respond fairly dramatically. Some don't respond, and when they don't respond, that's usually pretty obvious as well. So it kind of avoids things in the middle ground. You look at tumors like head and neck cancer and pancreatic cancer, and I think there's a lot more uncertainty just in terms of the tumor biology than we tend to have with lymphoma. So I'll go back in history a little bit and talk about the Chesson criteria, which is a little bit based on and similar to what we use for qualitative response assessment, just looking at the degree of activity and using that as a judge. I'll talk about the PERSIST criteria, which have evolved over time, become a little bit more simple in their application, but I'll show you some examples of the PERSIST criteria. And then I'll spend most of the time in what I use in clinical practice around the Deauville criteria, which have now led into the kind of Lugano response criteria for lymphoma. And that's something that I think many oncologists are used to applying these days. And I'd be interested to hear whether you find that in your clinical practice that you're getting requested to give them a numerical value. I certainly am.